every week we have a conference call, and Kim Eagle this last week was talking about a paper coming up in JACC and was saying that, you know, you get done with a TAVR and sometimes you see some rather alarming changes in the heart. And in a few weeks, there's kind of a return to normal, more or less. It's that more or less that gets to be an issue. And so we're talking about clinical and functional outcomes associated with myocardial injury after transfemoral and transapical TAVR. And I am with Dr. Lars Svensson, who is, as of January 2015, chairman of the Cleveland Clinic Heart and Vascular Institute. Thank you very much. This is a paper coming out in JACC Interventions. And we were looking through, what stories to cover, and that was one that Dr. Eagle said, let's talk about this, because after a TAVR, there are some injury items that you have to contend with. Usually they go away. What's important, what's not?
So that's a very good question. Is it important or not? Is it real? And clearly there is a leakage of enzymes, whether you look at CKMB or the troponins after these procedures. For the transapicals, it's a bit easier to understand because we're putting big stitches into the apex of the left ventricle. Right. And we did a paper on the first series of transapicals in the United States as part of the FDA study showing that about 17% of the patients had an enzyme leak. So that's explainable. The transfemoral group, the data is obviously real, and it has a very strong influence on outcomes. So the 30-day mortality rate in the highest tercile was 5 times higher than the patients in the lowest tercile. Very significant. And then that also played out in the 1-year data for the transfemorals. Transapicals, the cardiovascular mortality rate didn't influence, the enzyme leak did not influence 30-day or 1 year. The one big thing about the transfemorals, though, was that if there was an enzyme leak, there was no improvement to a large extent in the ejection fraction. Whereas the patients did not have much enzyme leak, they had a significant improvement over time of the ejection fraction.
Wow.
So what's going on here?
Exactly.
I think there are a couple of things. You'll notice in the paper that patients who had had previous coronary artery bypass surgery, or interesting enough, PCI, right, did not have as much of a leak. The CABG patients, we can understand that because they've got, in a sense, competitive flow from other sources when it comes to embolization. In the transapical patients, we prefer to do the transapical approach in patients who've had previous surgery. If they haven't had previous surgery, we usually go transaortic. So that's a factor there. In the transfemorals, I think a factor is that there's the collateral flow that protects the myocardium from potential embolic material. Now, in the paper, unfortunately, we don't have the incidence of coronary occlusion, PCIs for emboli, etc. And that happens. Yes. Fortunately, occlusion of the left main by the leaflets nowadays of the new valve or the old valve is uncommon because we measure the height of the left main, so we can figure that out fairly well. But the one thing is still, we occasionally, it's fortunately pretty rare that we have embolic material go down the coronaries. But 10 days ago, we had that happen to a patient of ours. So it was a transfemoral, S3, valve was put in, patient started going downhill very rapidly, was put on pump, we cathed the patient. There was a big embolus sitting in the LAD. We PCI'd that, cleared it. The patient from a myocardial point of view recovered, but had a massive stroke and unfortunately didn't make it. So the data we show in this paper is the enzymes, which is a marker, I think, of other problems. And if you look at the paper too, the patients who had the longer period of rapid pacing also had a high enzyme leakage. That could be because of the pacing, right, but it could also be because there were problems, and so, for example, embolic material causing a problem. So the question, I guess, becomes, what can we do about this? Yeah. And I think we just got to be more careful in the patients with atheroma in the arch. We've got to look at the calcium load on the leaflets. I suspect that over time, as we do more potential patients into intermediate group, we're going to see less calcium on those leaflets. That is, in a sense, treacherous to doing the procedure, and I expect the results will get better over time.
I mean, this was a sub-analysis of partner data, correct?
And the non-randomized continued access patients.
Right. So you have a large group of people, so you're pretty confident in what you're reporting?
Yeah, so we started off with a couple of thousand of patients. If you look at the patients where we had adequate data, it's about 500 in the one group, 500 and something, and 400 and a bit in the transapicals. So that's pretty strong data, and it's going to be a while before I think we see so much data showing it. But over time, my guess is this is going to get better.
So you talked about some of the things that are associated and some of the things that are not associated with outcomes, correct?
Yes.
Were there any surprises in there?
I wouldn't say any big surprises other than it would have been great to have the data on patients who had coronary occlusions, embolic material, or other issues, the actual events. I suppose one thing we could do as part of the publications committee is go back and say, all right, let's take the patients in the upper terciles in both the transapical and transfemorals, pull them out, and then do a chart review in a sense and find out what other procedures happen in those patients. And then maybe we'll be able to, in a sense, drill down more on the cause and the effect as far as.
I mean, that was one of the things you talk about, what's next, what further studies are needed, and that's certainly part of that.
That's something we can certainly consider to do.
So any last words of wisdom, particularly from this particular paper?
I think the words of wisdom are be very careful with a big calcium load. Look at those coronary arteries as far as their height above the leaflets, and that we've known for a long time. I think the way we do the S3 now with a more slow inflation, checking the position very carefully, that I think is a factor. I think we've seen the incidence of root rupture go down now that we don't do a very rapid deployment. And so that I think has helped that aspect too. So some of these patients would have been patients who had a root rupture. Now that root rupture, it sounds like a root rupture, but usually from a surgical point of view, when I've operated on these patients, the rupture usually extends down onto the muscle also. And so we have to repair the muscle, the annulus, and sometimes the ascending aorta when we have these root ruptures.
Well, the paper is in JACC Interventions. It is in the September 2015 issue. Please check out that paper out from Dr. Svensson and colleagues. For CardioSource World News, I'm Executive Editor Rick McGuire.